Hello and good afternoon. Welcome to the first webinar from our Cardiovascular Issues in Primary Care, titled Pressing Matters: How to Approach Hypertension, hosted by the Office of Lifelong Learning and the Physician Learning Program at the University of Alberta. My name is Donna Manka. I am a professor emeritus, a family physician, and a network director of the Northern Alberta Primary Care Research Network, as well as a medical director in the Physician Learning Program and L3 Learning Program. The Physician Learning Program and the Office of Lifelong Learning are committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to the best care of our patients. Firstly, I really think it's important to acknowledge this land that we work on. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Cree, Blackfoot, Stoney, Denny, Iroquois, and Ojibwe lands that are now part of Treaties 6, 7, and 8, and the homeland of the Métis. The University of Alberta respects the sovereignty, lands, history, languages, knowledge systems, and the cultures of all First Nations, Métis, and Inuit nations. For housekeeping information, I'd like you to use the chat feature if you have a question about technical difficulties or L3 programs and services. If you have a question for the speaker, please use the Q&A feature of the webinar. Please review what has already been asked and upvote those questions that you would like answered. We cannot guarantee the panelists will be able to respond to all of your questions. A recording of the webinar will be sent by email to all of those of you who have registered. Participants can claim CME credits and complete a personal development activity using the My Lifelong Learning Plan tool. For information, look at the QR code that's being displayed on the screen, an excellent resource. This activity has not been formally reviewed by the Canadian Family Physician or the Royal College. However, this webinar is eligible for non-certified credit. Main Pro Plus participants can also earn additional credits by completing a linking learning exercise. Today, we are very lucky and pleased to welcome Dr. Raj Padwal. Dr. Raj Padwal is a professor of medicine at the University of Alberta, a general internal medicine specialist, a clinical pharmacologist, and a clinical epidemiologist who is practicing at the K Edmonton Clinic and Diamond Healthcare Center. His specialty focuses on hypertension, lipids, and cardiometabolic disease. He has received over $7 million in peer-reviewed funding from various sources such as the Canadian Institute of Health Research, Alberta Innovates, and the National Research Council of Canada Industrial Research Assistant Program in the fields of technology and assisted care and blood pressure measurement. He has published over 300 peer-reviewed papers. He is a past chair of the Canadian Hypertension Educational Program Guidelines and a member of the National International Blood Pressure Guideline Committees. And he is a past CEO of the Millimeters Mercury Incorporated, focusing on creating sustainable, scalable software platform solutions that enable best practice. We are very fortunate to hear from him today, and welcome to you and to our prestige speaker. And I'll turn
Thank you.
over to Padwal.
Thank you, Dr. Mecca. So first of all, it's great to be here. Thanks very much for the invite to present on one of my favorite topics. If I don't get to questions, you can feel free to email me, and my email is shown at the bottom of this slide. In terms of disclosures, the most relevant one is in bold. and that is Medtronic. I have been part of an advisory board for them for their technology called renal denervation. That is a procedure that does lower blood pressure. We do it in Edmonton. It is done for patients who have exhausted all other treatment options. I may talk about it at the end in terms of full disclosure. Otherwise, the remaining things on this slide are not particularly hypertension related. Before I begin, I just want to give a little plug, I guess, for our clinic. We don't have a particularly long wait list. We certainly welcome referrals. CV risk reduction is what we do, particularly hypertension and dyslipidemia. From the hypertension perspective, we like to see the resistant severe cases, but we'll see any case you want to send to us. And maybe not well appreciated, we do a lot of dyslipidemia work. I'm the one that does most of it. Have a particular interest in familial hypercholesterolemia as well as high lipoprotein A. But again, we're happy to see and try to help out with any case that you want to send over. We have 10 physicians, 2 pharmacists, and we run that clinic every week. Referral numbers are shown at the bottom. Okay, on to the talk. So what I thought I'd do is a case-based discussion and weaving in then what is the latest from the hypertension guidelines. Unfortunately, we haven't had new Canadian guidelines for some time. I'm not involved in the Canadian guideline process, haven't been for several years. I gather they are updating, but the Canadian guidelines as they currently stand, I think, are a little bit out of date. The international guidelines have really taken their cue from the US guidelines, and everyone is pretty much saying the same thing. There are some slight differences, so I'm just going to focus on the most recent published ones, which are the ESC guidelines, because really the messaging is the same across all guidelines nowadays. And like I say, the Canadian guidelines probably when they become updated, will align mostly with what's being said internationally. And then we'll talk about diagnosis and management, the latest recommendations as we go through the cases, 2 cases, maybe 3, and then secondary and resistant. I think it's really important that there's one aspect of resistant that you're very aware of because you're probably seeing a lot of it and possibly not realizing it. So let's go through a case. So 52-year-old female, and I've bolded the salient features. So 15-year history of hypertension, positive family history, comes in palpitation, flushing, and headaches. So paroxysmal symptoms. Recent ED visit for BP 220 over 120, so severe elevation. 155 over 75 is the most recent mean of a 7-day home BP series. Heart rate is high normal, and BMI is elevated. You can see the medications listed there. I've bolded the fact that this patient is on medication for ADHD as well, amphetamine derivative, which may, as you all know, raise heart rate and blood pressure. Intolerant of beta blockers. We'll talk about the medication regimen in a few slides. Okay, so I guess we'll go ahead and put up the first poll question. And while we're okay. So of the possible cases of hypertension, which is the least likely contributor? Primary or polygenic, PHO, obesity related, or medication induced? Okay, I guess oh, there it is. Okay, so least likely 54% PHO. Yeah, so that, and we do have answers spread across all of the potential answers. So just to move on, so I would say the least likely contributor is PHO. I'm just trying to get you think about the case. I mean, it's not really a right or wrong situation. This patient could turn out to have FEO, but the bottom line is we always think about FEO and we always teach about FEO in medical school, but really, one in a million, it's very, very rare, and you have to go by pretest probability. And I would submit to you that this patient has multifactorial hypertension, and all of these factors play a role. So I wanted to talk very briefly about etiology of hypertension simply because I think it gets kind of glossed over a lot of times. And this slide, I know it's busy. It shows how complicated hypertension can be. Many factors can contribute to blood pressure elevation in a given patient, some of this endogenous and some of them exogenous. But I would submit to you, as busy clinicians, we can focus this down and don't forget about primary. And I would suggest that you add primary as a diagnosis in the patient's record. I prefer primary to essential. I don't like the term essential. It has different connotations. Primary is when they have a family history. Now, not all family history positive hypertension is primary. Sometimes it's monogenic secondary, but that's very rare. So the vast majority of cases, if the patient has a family history, it's probably primary. Polygenic in nature, over 1,500 genes contribute. Often patients will have scores of genes and they all add up, each contributing a very small amount. And it typically is presenting maybe late 30s, usually 40s, 50s, 60s in the absence of obesity. So I think it is important to identify primary because it gives you information on why the patient may have high blood pressure, and you may be less likely to worry about a secondary cause if it's in the setting of primary. You may or may not, it depends. Obesity is another really important one, of course, especially in younger patients. And often I'm not doing a huge secondary workup if I'm fairly convinced clinically that it's obesity related, especially central adiposity related. And third is the large artery stiffness or the isolated systolic hypertension. These patients tend to be very elderly or elderly. They have hypertension for many years. The phenotype has kind of distilled itself into a large artery stiffness phenotype. They get early vascular rebound. The systolic goes up, the diastolic goes down. And just a reminder, treat the systolic aggressively in these patients if clinically warranted, because the stroke risk is very high. Even if the diastolic is low, that's not a reason not to treat. Just be wary and question the patient about angina or angina equivalent, which may happen when the diastolic is dropped too low, but I haven't seen it very often clinically. So important to treat isolated systolic hypertension. So the key points here are most of what you'll see in clinical practice: primary hypertension, obesity-associated hypertension, vascular stiffness, primary aldosteronism, and more on that in a little bit. So here we go back to the case, and we see that this patient has palpitations, flushing, and headaches. And so we talked a little bit about whether this could be FEO, but I think, as we mentioned before, very rare condition. Definitely medications can be contributing to elevated blood pressure, and in this case, the amphetamine derivatives. So when I look at secondary causes of hypertension, we have all of them listed here. The renal are divided into renal parenchymal and renovascular. You have endocrine. You have the very common ones, obesity and weight related, especially central adiposity. And then you have thyroid and hyperparathyroidism. The latter two are not usually just a BP issue. And so in those instances, those patients are not typically presenting just with hypertension. And then you have coarctation. Now, there was a question about presenting symptoms and how often do patients present with symptoms? And the answer is not very often. Most hypertension is asymptomatic. Sometimes patients may complain of headaches or dizziness when the BP is high, but otherwise, it's really what they're presenting with is the symptoms and signs related to end organ damage or secondary causes. Now, we all know the end organ damage, symptoms and signs. Often patients are not presenting with this initially. If they are, it's asymptomatic elevation in creatinine. And then secondly, it may be early heart failure, other than them presenting to the hospital with a stroke, for example, or an MI. But typically asymptomatic with some end organ damage found on labs. Now, secondary hypertension, important for you to have a general knowledge of, especially the first one, primary hyperaldo. It's very common. It may actually be up to 20% of all hypertension. So really important to know that it exists. Often patients are asymptomatic. Sometimes they may present with low potassium and associated symptoms. Sometimes they have a very strong family history of hypertension. Renovascular, especially the fibromuscular dysplasia, there's two types, FMD or atherosclerosis. FMD, young to middle-aged women. Atherosclerosis in people, those people present typically as smokers or diabetes or other atherosclerosis in other vascular beds. If they have a history of migraines, pulsatile tinnitus, previous aneurysms in other areas, they may have FMD. FMD is not a common diagnosis. I don't look for it all the time, but those are the clues to think about it. Cushing's is Cushing's. I mean, it can be very challenging to pick up. I've picked up 3 this year. It's a record for me. I think the virtual care is actually reducing the amount of recognition that increasing the number of missed cases of this fairly rare condition. So important to see patients at least once. I always try to see patients at least once when I'm assessing them, in order to make sure that this is not present. Sometimes it can be very subtle, and so you have to test periodically over time if you still suspect it. FEO, I'm not always looking for FEO. Why? Because we see a lot of false positives, especially people on TCAs and SNRAs. Also ADHD meds. And so when you get false positive, you're sort of chasing them, wondering, oh, what do I do now? So it's better not to test unless you suspect it. But in this case, the trigger for suspecting it is not so much the paroxysmal symptoms, because lots of people have paroxysmal symptoms. It's more the issue that the blood pressure was severely elevated. She ended up in emerge. Renal parenchymal is easy to rule out. You do a creatinine, you do and a GFR, you do an ACR, you do a urinalysis, and you do abdominal ultrasound. Okay, so for secondary causes, when do we look? Everything's listed on the left-hand side, but it's basically early onset hypertension or severe or resistant hypertension. Sometimes if they have some of those symptoms or signs I previously showed. Now, my screening hierarchy is on the right, and it's really divided into what can I easily rule out. So obesity, sleep apnea, medications, renal parenchymal, those are testable or pretty obvious. Category 2, primary aldosteronism. So we'll talk more about it in a minute, but there are guidelines coming out that are saying just screen anyone with hypertension. Maybe it's a bit radical, I don't know. But I think where people are coming from is it's missed all the time, and picking it up changes management. If you're not going to screen everyone, it's the patient who has severe or resistant or early onset hypertension, or the patient with an adrenal adenoma. Some people may add atrial fibrillation, early onset, or sleep apnea in there, but essentially, you can screen liberally, and that's hopefully one thing you get out of this talk. Category 3, only if symptoms, signs, family history, abnormal imaging. And I think out of this one, FEO in this case, I would screen for. Cushing's, I wouldn't unless I clinically suspect it. And then category 4, I kind of leave at the end because it requires a CT angiogram. Now, of course, if there's some clinical suspicion, then I'll just go right to it. But if not, then especially in the obese patient, you're wondering, really, should I be doing CT angiograms after I'm done a secondary workup on every obese patient? Because it's probably the obesity, right? So if the patient's thin, the blood pressure is severely elevated, and I don't have a reason for it, then I'm thinking about CT angio, or if there's symptoms or signs suggesting FMD. ASCVD, atherosclerotic renal artery stenosis, usually these people are 60 or over and they have had a history of smoking or diabetes. I won't always be looking for because it doesn't usually change management unless I can't get the BP controlled. Okay, the top one for screening, what do you do to screen? The top one you should know. Please know to do an aldosterone to renin ratio. I apologize, it's a cumbersome test. We don't have great tests for PA, unfortunately. Unfortunately, it's often clouded by the medication, but I still think, and experts still think, we should be asking primary care to screen and send if it's positive, and then we can sort it out whether we think it's a true positive or not. Usually the direction of bias, though, in the testing is a false negative because a lot of the medications can cause false negative. Make sure the patient goes between 7 to 10 a.m. Renovascular, as mentioned, CT angio is the best test. You could do Dopplers. I see some patients come in with Dopplers. It's very operator dependent, so you never really know if you're getting a good result. Cushing's 2 of 3 tests, and the tests are listed there. I'm typically doing dexamethasone suppression because people are often being referred to me with an adenoma, and that's the best test in the setting of adenoma. Pheochromocytoma, I'm typically doing plasma metanephrines because it's easier for patients than collecting 24-hour urines, and renal parenchymal, as mentioned previously. Okay, so on with the case. So suffice it to say, for the sake of time, the screening for pheo, renal artery stenosis, primary aldosteronism were all negative. So then we move on. And we say, okay, what are the etiologies? I think primary because of the positive family history. Obviously, obesity related, probably the central focus here. And then contribution of medications and oral contraceptives in women, NSAIDs, alcohol, maybe more in men, but both, but especially in men. That's often a driver of hypertension. 3 drinks a day or more is a threshold that will really start to increase blood pressure substantially. And these medications here, SNRIs, venlafaxine may raise heart rate and blood pressure. So those are the more common causes of medication-induced. And a lot of people come in with this, but it's not possible to change the medication, so we treat around it. Now I want to draw your attention to what do we do? Okay, so the blood pressure is elevated, 155/75. We have candesartan, we have diltiazem, we have hydrochlorothiazide, we have the ADHD med as well. We have this intolerance to beta blockers. So what do we do? Well, before then, I'll just go over what the guidelines say, what to do and how low to treat, but let's see what you guys think. As per the contemporary guidelines, what is the treatment target? So we can go ahead and put this poll question up. Less than 130, less than 140. This is for systolic. Less than 150, less than 120. Okay, so really knowledgeable group, 60% less than 130. And that's really over the years, it's gone from, in some cases, recommending less than 160 down to 140, then 135, which is what the Canadian guidelines typically will say. Now 130 in a lot of the international guidelines, that's the correct answer. I know you're probably thinking, how can you get to 130 in a lot of your patients? I agree. I don't often get to 130 in my resistant hypertensive patients, but I do try. I try as long as I can get there within 3 drugs and the patient's on board. If I'm doing things like adding hydralazine or clonidine or something like that, alpha blockers, I'm maybe not trying to get to 130. The evidence shows, and I didn't put all the trials and studies in, just giving you the bottom line. This is from the these are ESC, not ESH guidelines. And you can see the class 1 recommendation is basically a number needed to treat of about 80 to 120. So let's say 100 over 3 to 4 years in the higher risk patient population. So multiple risk factors, advanced age, known cardiovascular disease. So it's not a super compelling number needed to treat, but when you think about every 100 patients you see, one out of 100 patients, you'll prevent an event over a 3 to 4 year span. It's not something to be ignored either. So try to get under 130 if you can. Now, I will say that there are instances where you can't. A, limited life expectancy. B, sorry, I'm going to skip to this slide first. B, clinical frailty. And I like this CFS, clinical frailty scale. I imagine you all must use it for maybe other reasons in your practice. If people are getting to vulnerable, I'm starting to think about whether I really want to be driving their BP down, and it goes hand in hand with life expectancy as well. Mildly frail, it really also depends on shared decision making and what the patient wants, but moderately frail, definitely not trying to get intensive blood pressure management. That's my practice. So here we have the algorithm for how to treat patients. So basically the same across all guidelines now. So if you're targeting to get to less than 130 systolic, 80 diastolic is the corresponding one, although there's much more evidence for the systolic target. Then you should use ACE or ARB. Dihydropyridine, CCB, is typically what's used. Thiazide diuretic, I use thiazide-like diuretic. My favorite agents, they're all generic, are telmisartan, amlodipine, and indapamide because they're all long-acting. But you can use whatever your favorite agent is. Try to pick long-acting drugs, though. And if they're not controlled after a month of reassessment, it takes about a month to 4 to 6 weeks for full effect of most of these agents. You reassess every 4 to 6 weeks, add on what you don't have in that list. And if you arrive at uncontrolled blood pressure and you think they're taking their medications after they're on triple therapy, that's the definition of resistant hypertension. So that's basically what we do. I do start with amlodipine a lot, actually, and that's because I kind of gravitated towards it in the pandemic. And nifedipine long-acting is fine as well. It just doesn't require any monitoring and subsequent lab work, etc. So that's why it's a nice one. But whatever your favorite is amongst those three, there's evidence for all of them. And then if patients are not controlled, you could consider referral. You could do a little workup, adherence, secondary cause. Often we'll do a 24-hour ambulatory BP as well. And you've confirmed that they are resistant, then spironolactone, you'll control 95% of people if you add low-dose spironolactone 12 and a half to 50 milligrams. Make sure you screen for primary aldosteronism first, though, before you add the spironolactone. Otherwise, we have to stop the spironolactone, go back, screen if indicated. Sometimes we just keep them on the spironolactone, but if we think there's a chance they may lateralize and they're young or middle-aged and they may want surgery and they end up having primary aldosteronism that's surgically remediable, then we have to stop the spironolactone for 6 weeks to rescreen them. If the heart rate is high and they're on the triple therapy regimen that's recommended, I will add a beta blocker instead because it works really well. And just to show you, I mean, busy slide, but just to show you that all the guidelines gravitating towards the less than 130 target in most patients, especially the higher risk patients, if you can achieve it. Remember the if you can achieve it part of that, though. So that's the key point. And frailty, limited life expectancy, those are two reasons why you need to amend that target. Also, of course, if the patient's not on board. So in this case, what did I do? I increased the diltiazem. The patient was on diltiazem, I think, because the heart rate was high because of the lisdexamfetamine. Otherwise, the patient's usually on amlodipine or nifedipine instead. Hydrochlorothiazide, I like thiazide-like diuretics, sorry. I find that they're a little more effective than hydrochlorothiazide. I won't always switch, especially if it's a combo. I won't break a combo usually because combos help adherence. But I will often switch if the BP is uncontrolled. Added spironolactone. Her family doc switched her from lisdexamfetamine to a less activating one, is my understanding, and Anyway, the BP came down, and then family doc started semaglutide. And what a response, right? So we've all seen cases like this, 40 pounds of weight loss, still losing weight. And I started to dial back the medication. So I think it's a really informative case for going through what we do in contemporary practice, but also look at what happens when the obesity is treated. And personally, I'm starting to wonder, and I know others are too, if these guidelines shouldn't be amended to have the obesity therapies up front and center before you start doing other things. Because look what happens. You get less medication. Now, obviously, not everyone can afford these medications, and unfortunately, and not everyone can tolerate them. And so they're not for everyone. But certainly when you treat the obesity and the weight comes down and the blood pressure comes down, it's very gratifying that you can stop other medications. So hopefully it's a durable response. Of course, that is always the concern. We'll have to see. Obesity, hypertension, not going to spend too much time on physiology, just to say sympathetic nervous system activity, salt and water retention. So really all of the major reasons why blood pressure goes up, endothelial dysfunction, inflammation happens in obesity, especially central obesity. And really important to try to get that weight down, whether it's through pharmacological or hopefully non-pharmacological means. Now, there was a pre-question about exercise, so I thought I'd just put a slide in looking at all the things for non-pharmacological. There are recommendations to increase potassium intakes, particularly through diet, as well as increase physical activity, optimize weight management, of course. Some people will recommend salt substitutes like potassium chloride instead of sodium chloride. There's a large trial in China on a population level showing that it did reduce population blood pressure. Alcohol intake, especially 3 drinks a day. Obviously, there's reasons for cancer prevention or cancer risk. I mean, it's observational data, but it's reasonably compelling to reduce alcohol intake further and smoking cessation. Now, the question was about what to recommend for exercise. I'll recommend to my patients now, I'm a little aggressive on the exercise end of things. I hope I don't turn patients off by that, but I figure you might as well aim high. I tell them I want them to work up to an hour a day, 6 days a week. I don't know how many do that, but I've had some really good successes in my practice with people who do take it to heart and actually make changes. And I tell them to do, or I ask them to do, a triple 3 days of endurance training, B, resistance training, and C, flexibility like yoga, Pilates, Tai Chi, something of that nature, and then repeat it and then take 1 day off. But if you look at what the guidelines recommend, it's basically 150 minutes a week of moderate intensity or 75 of vigorous. And then they say mix it up to do some aerobic or endurance training and some resistance training, whether it's isometric or dynamic, whatever the patient likes to do. And the evidence, 197 trials, over 10,000 patients, it does reduce blood pressure, 5 to 10 millimeters reduction is, so you're going to get about the same as you get with a medication if people take it to heart and actually do it. And you get better results, combination of different exercises. The flexibility training I find really does help to prevent injury as well. You obviously want to counsel patients to ramp up slowly and never just go from 0 to 100 right away. That's just a recipe for injury. Okay, so I'm going to move on to the second case. 43-year-old male, South Asian, so relevant because higher CV associated with higher CV risk. And I'll just draw your attention down to the BMI. This I would consider 27.4. You may consider this to be an obese BMI in a South Asian, especially someone with central adiposity and the metabolic syndrome. You'll notice that the triglyceride level is high. So this is a person with metabolic syndrome, resistant hypertension, 10 years history of hypertension, asymptomatic, coming in with a BP that's fairly elevated as the mean of the home BP series, and is on triple therapy, so the dihydropyridine CCB, the telmisartan, so the ARB, and hydrochlorothiazide. So BP uncontrolled, so very definition of resistant hypertension, 3 drugs, maximum dose, maximally tolerated doses, one of which is a diuretic. And I'll also add that the potassium 3.1. Ooh, wow, darn. I guess we can skip the next poll. I didn't, I mixed and matched these slides too carelessly. So I answered the question, but so we don't have to bother with the poll. But which secondary cause would be highly suspected and important to rule out? Well, I've kind of mentioned it all along. I mean, pheochromocytoma is very important to rule out. It's a devastating condition, but it's just so rare. So your pretest probability is very low. Renal artery stenosis in a 43-year-old. Yeah, it's possible. I mean, fibromuscular dysplasia affects young to middle-aged patients, but typically women. And we don't have any history of migraines, pulsatile tinnitus, or aneurysms, or family history of same. And by the way, when you're evaluating for renal artery stenosis clinically, always listen at the back. So renal bruits are best heard in the CVA angles, so posteriorly. Cushing's, yeah, he has central adiposity, but wasn't Cushing-like in appearance. And then primary aldosteronism. So the low potassium can be seen with Cushing's. I mean, it's a mineralocorticoid effect, but it's more commonly seen with the aldosterone secretion that is found in primary aldosteronism. So the answer is primary aldosteronism. Now, this is not a diagnostic question, but I realized that I didn't have a case on diagnosis. Well, I had one, but I took it out because I thought it would take too long. So I did want to throw in some slides on diagnosis so that we are complete in terms of the overview of what the guidelines are saying. And this is what all the guidelines are saying now across the world. They're defining elevated blood pressure as 120 to 139, 70 to 89, and you can see the corresponding home and ambulatory range. And so, like, most people will have elevated blood pressure actually based on this. And that's it's supposed to be a trigger to tell people to focus on health behavior modification. I don't know many people that will have a blood pressure less than 120 over 70. But from the clinical perspective, from our, us hardcore clinicians seeing patients, it's really this right-hand column that's the most important. If you're going to diagnose via office, then a lot of the European guidelines, they still use office, so 140 over 90. Otherwise, home BP series or ambulatory, 135 over 85. If you use office, please pay attention to proper measurement, proper cuff size, 5 minutes of rest. I mean, it's so hard to do that in a busy outpatient setting. I would never be able to do it. It's too busy. I don't even really measure BP in the office unless it's something that I'm suspecting. On the initial visit, we'll do it in each arm to make sure there's not a huge difference. If a coarctation is suspected, we'll do it in the leg as well. But other than that, I'm depending on home BP. So I spend a lot of time talking to my patients and demonstrating to them on successive visits proper home BP technique and reinforcing. And I ask them to bring their device in on the second visit so that I can look at it and make sure the cuff size is correct and that it's a validated device. But you can do whatever's best for your practice. You can use office. It's just that 50% of the time, it may give you the wrong decision, i.e. masked or white coat hypertension. And the direction of bias is typically in the white coat, meaning you may be over-treating people if you're using office BP. So I would rather that you use home BP, especially for follow-up, and ambulatory BP for initial diagnosis if you have access. And by the way, we have a BPM program. You don't have to send in the consult for us to see. You can just access the program for doing an ambulatory BP monitor, and it gets read by one of us and the report sent back to you. Or you can put it into your practice. You can unfortunately, the billing code was restricted to internists because that's who supported it. So any internist, cardiologist, etc., can bill it, but you could partner up with one to run a program in your setting if appropriate, or the radiology, Insight, etc. I think they offer it as well. Just make sure the patient doesn't pay because I don't think the patient really should have to pay anything for ABPM. There is a fee code. I mean, it took a long time to get that fee code in. So I really hope that patients aren't getting charged a surcharge. I use ABPM for initial diagnosis unless the patient doesn't want to do it. In that case, I do a careful home BP series, which I may repeat a couple times. A home BP series is 7 days, and you have to make sure you go over technique with them and reinforce it because that's the really, if you're going to depend on these numbers, you have to make sure that to the greatest extent you possibly can that the patient's doing it properly. Some guidelines recommend a first day discard. I don't do first day discard. I just average everything together. Sometimes they don't give me 7 days, but if they gave me 3 to 5, then that's good enough. I'll just use what I get. It's still way better than episodic office BP. So that's the key point here. And then if you want to go to Hypertension Canada website, oh, by the way, for the non-pharmacological stuff, they have reasonable handouts at Hypertension Canada for patients so that you can give them some literature on what to do if they have high blood pressures, low sodium, et cetera, et cetera. They also have this validated device registry, which was started when I was still around there, and we made sure that it listed all validated devices in Canada. If you're going with a Japanese manufacturer like Omron or A&D Medical, which is often called LifeSource, then those are always validated. So those are good ones to recommend. BIOS is a third one that is validated as well. But you can direct people to the registries. It's a little bit cumbersome for them to look through it, but that's sometimes what I do, or I just name those types of devices and say, please go and get one of those. And I spend more time making sure that if their arm is large, that they get a proper cuff size and they're using proper technique. So back to this case. So this gentleman had positive family history, so he probably has some primary central adiposity, so he probably has obesity-related hypertension, but his potassium's low and his blood pressure is quite high as well. So we would look for PA in this patient, definitely low potassium, severe hypertension, relatively young, even though he has other explanations potentially. He has resistant hypertension, and that's another reason to look. So back to my screening hierarchy again, obesity, sleep apnea, considering him medications. I don't think he wasn't on any medications that raise BP, renal parenchymal. Everyone gets a urinalysis and a creatinine in our clinic, of course. ACR as well, if we suspect anything. And then PA. So we're thinking about screening him for PA. Okay, what is PA? PA, like I said, 10 to 20% of all hypertension maybe. It's autonomous aldosterone secretion from the adrenal glands. Autonomous meaning it's not regulated. It escapes renin regulation and the renin is suppressed. Okay, so the autonomous aldosterone is escaping and renin becomes suppressed. Mostly patients are asymptomatic. Sometimes they have diuretic provoked hypokalemia that's excessive in your opinion or my opinion or spontaneous. Sometimes atrial fibrillation or disproportionate target organ damage, or sometimes they come to you because they have an incidentaloma and you're wondering. Then you have to do the triple workup, PA, Cushing's, FeO. And for your purposes, you just need to know to do the aldosterone-renin ratio. All this other stuff, confirmatory testing, which I actually don't do, adrenal venous sampling, which is really cumbersome to arrange and hard to interpret. All of this other stuff you can leave to us. But it's really geared towards figuring out if it's unilateral or bilateral. If it's unilateral, then we would treat with sending them for surgery if the patient wants. If it's bilateral, then we treat with spironolactone. If not tolerated, a eplerenone or others. And if the patient doesn't want surgery, sometimes by default, we just slap them on spironolactone and see how they do. Now, if you're in the Edmonton region, every lab is different. Calgary's labs are different, so you have to pay attention to what the recommended cutoffs are, and it should be hopefully on the lab result, what is a positive test. But in Edmonton, aldosterone to renin ratio of greater than 140, greater than 100 is borderline, greater than 140, you're suspicious this is PA. And I won't do confirmatory tests. I'll just repeat this once or twice and make sure it's consistent. And if it is, then I think they probably have it because it's so common. Unfortunately, you get false negatives from a lot of the medications, beta blockers, false positives. But I think you should still screen, and then if it's positive, send them along. Or if you're worried about, you missed it, send them along as well. I think that it's worth it because, as I mentioned, it does change our management. This is just to show you how complicated it can get with adrenal venous sampling, adrenal CT, trying to figure out if we should go for surgery or not. In Edmonton, I think we're pretty conservative. If we're unsure, we'll probably just go medical therapy. In Calgary, they're much more aggressive. They have a couple real world experts in Calgary, and they're a lot more aggressive in terms of sending for surgery. But I don't know if it's a confidence issue in Edmonton or not. Also, there is a lot of literature showing that if it is unilateral initially, then the emerging literature suggests that it may also be in the second gland. It's just it's in the first gland earlier. So then I'm a little less comfortable with sending for adrenalectomy. But if it's a rip-roaring case of a young patient with a 3 centimeter adenoma and they're quite positive on their biochemistry, that's a case where the adrenal can be taken out if it lateralizes on AVS. So in this case, the aldo was very high. You'll recall 400, 440 is sort of a high, so 1,000. The renin is suppressed, 3, 4, 3, less than 3. Often these patients come back and their renin is less than 3. The ratio is 320, so you'll recall 140 was the cutoff ratio. So this patient has a PA. A CT abdomen shows a left adrenal nodule, and adrenalectomy was performed. So I see the time is 11:46, so I'm just going to finish up because I do want to leave time for questions, etc. So please think about PA and screen. Now, the last case I'm just going to burn through because I don't think it's super important we go through all the details. It's a 67-year-old gentleman, patient of mine with elevated BP, and this severe hyponatremia that I bolded. This is a big problem when you have that because if you have a patient with hyponatremia, chronic, induced by whatever, often it's dietary induced as well or propagated, then you can't use thiazide, you can't use spironolactone. It's very difficult to tolerate and it's very difficult to get a resistant hypertension patient to target. So the patient was on telmisartan amlodipine and an alpha blocker. And we did try other medications. They didn't really work. So we have this whole algorithm for resistant hypertension, but I've mentioned the elements before. It's to diagnose resistant hypertension as per the definition, consider ABPM, adherence counseling, secondary workup, and then that ACE/ARB slash CCB slash thiazide-like diuretic combo. That's what we always want as our core combo and long-acting agents. And then we go spironolactone, and if not, we go other medications. So the point of this case is that if you've exhausted all options, or if the patient is not able to tolerate, then we can consider renal denervation. And renal denervation, just so you're aware, it's kind of based on the literature. It was very old from the 1930s and 40s. Sympathectomy used to be done for hypertension when nothing else was available. And they did lower the BP quite a bit, but lots of problems like orthostasis and impotence occurred. So renal denervation is where you lie the patient down, and cardiologist Dr. Dorsch, Misha Dorsch at the ALEC is the one that's doing it in our program. You put the catheter up the femoral artery or radial, sometimes they use a radial approach. You get into the renal artery and then you use radiofrequency ablation to get rid of some of the renal nerves. Efferent and afferent to reduce sympathetic activity and reduce blood pressure. And on average, the blood pressure reduction is only about 5, maybe 10 millimeters mercury. Not everyone responds. Some people respond more than this. That's why we don't use it routinely. That's why we're using it in high-risk patients as a last ditch when everything else has sort of been exhausted. I just want you to be aware of it. This patient got it. He dropped by 10 millimeters, and then he dropped some more weight, and his blood pressure came down even more. So he's probably more rate related, but the renal denervation did help this particular patient. And that's basically it. So I'm going to wrap up and just give you the key points. BP less than 130, use out of office. PA is really common. Please think about it. And that's it. So I'm going to stop sharing now.
And thank you so much for that excellent presentation. And before we move on to Q&A, I'd like to remind people about an excellent resource that provides you data so you can see how you're doing. So the Northern Alberta Primary Care Research Network is a practice-based learning and research network that collects data from electronic medical records in Northern Alberta. There's a southern one as well. We contribute data to the CIPSN, the Canadian Primary Care Sentinel Surveillance Network, which has cleaned and structured the data for the purpose of quality improvement, surveillance, and research. It can be used for improvement at many different levels. At micro levels for an individual physician, meso through PCNs, we've provided PCNs data on how they're doing, and macro, we're involved in a lot of national and international projects. So there is an example on the screen of the type of report that the physician learning program working with our network has allowed us to develop for participating sentinels. So if you have an electronic medical record and you're interested in seeing how you're doing and contributing to primary care research, consider this. You can see how you are doing compared to your practice and compared to the overall network. And this is an example of a report regarding blood pressure. So we are looking at things like how well blood pressure targets are met. Are you seeing your patients, in adequate timeframes? And we have a new report coming up looking at undiagnosed hypertensive patients in practice. So there are patients that have elevated blood pressures on visits that are not being identified as having high blood pressure. And then with that, let's move on to the Q&A, and there are lots of questions. The first question that is listed is, do we test for primary hyperaldosteronism only if potassium is low or otherwise as well?
Yeah, you should test for it even if the potassium is normal. Most phenotypes have a normal potassium, and the particular phenotype you should look for if you're not testing everyone with hypertension is people who have resistant or severe or early onset hypertension, or those that present with adrenal adenoma. Of course, if they have hypokalemia, that's a trigger to investigate hypokalemia and hypertension. And some would say sleep apnea, atrial fibrillation, look for PA as well.
And then the next question is, semaglutide going to have universal coverage for obesity purpose anytime soon? It's currently not covered by IFHP or Alberta Works. Not sure if you know.
Yeah, I'm not sure. I mean, I think it's a matter of competition, right? So when more competition comes, the price will go down and coverage will occur. But honestly, I don't follow the space, that part of the space close enough to know, but hopefully, because they're such great therapies in particular patients, and it sucks when a patient can't afford it.
No kidding. The next question is, should patients with diabetes and hypertension specifically be either on an ACE inhibitor or an ARB? And does it matter if they have a chronic kidney disease or albuminuria?
So for sure, you should start with ACE or ARB if they have CKD albuminuria. But you don't have to if they don't. All HAT showed that the outcomes were similar. All HAT was a 40,000 patient trial. But I would say, I typically will start with ARB. I use ARB more than ACE. I think the evidence is reasonably equivalent, and I don't want to deal with angioedema, and I don't want to deal with cough. So I'll go ARB over ACE most times. Not always, but most times. But I would say if they have diabetes, that's what I go to first line in almost every case.
The next question is, if deciding to initiate treatment with two drugs, what is your go-to? Is it a combination pill or two separate pills?
Yeah, thanks for reminding me. I kind of glossed over that. It was in one of the slides where I usually go 160 over 100. I'll do two drugs if the blood pressure is at that threshold or higher. The guidelines actually say you can go two drugs even with lower thresholds, but I often see in clinical practice on a practical level, if you start monotherapy, amlodipine 5, there is a wide spectrum, telmisartan 40, indapamide 1.25, there's a wide spectrum of response to that. And often you can get away with monotherapy and they do get to target at half strength. Then you're faced with the decision, do I double it more side effects if you double it versus adding a second drug. And what do? I usually will go ARB CCB, so telmisartan amlodipine. There is a combo, but that's one of the few branded products left. And sometimes patients don't want to pay for it, so they'll just stay with the monotherapy because the single pills are generic as well and quite cheap. Or I'll go perindopril if I'm using an ACE indapamide, or I'll go ARB thiazide like diuretic. So if I'm gonna do combo, uh, I'm kind of all over the place, but I would say 80% of the time I'm going ARB CCB. And again, with COVID, I kind of learned to do that so that people wouldn't have to go to do labs that often. But that's just me. I don't think there's any right answer. You can do any of those three main core groups. You can combo them as you wish.
The next question is your thoughts regarding morning versus bedtime dosing.
Yeah, I'm laughing because Donna and I are lucky enough to be working with a lot of people that are working with Scott Garrison, who's an amazing researcher, and he's doing the BedMed trial. But I think the bottom line that's come out so far prior to BedMed is that it probably doesn't matter. And I think the most important thing is when patients are going to remember to take their meds. That's really the bottom line because you want to use long-acting meds. So if you're using long-acting meds, just basically when they are remembering to take it. One caveat, amlodipine, some feel less swelling at the top dose if you take it at bedtime. So amlodipine bedtime, maybe if you're trying to avoid pedal edema.
And then, if an elderly patient has hypertension for a long time with three different agents, including thiazides, develops hypokalemia, which then resolves without discontinuing treatment with oral supplement, should we screen for PA?
Yeah, it's a good question, Eugen. I mean, I think you should really, I think the flavor of my talk is there's going to be guidelines coming out soon that say screen for PA with anyone with hypertension. So I don't think it's ever wrong to screen for PA. I don't think anyone could ever fault you for screening for PA, whether it's this scenario or not. I think in the olden days, like in the last few years or decades, we would screen if the hypokalemia was quite profound, but that's a subjective thing. Maybe if they end up in the hospital with hypokalemia, but I think ultimately you can screen definitely in that case, and you can even screen more liberally if you want to.
And then, how long do we need to stop the drugs mentioned to test for aldosterone renin ratios?
Yeah, I really glossed over that because it's a big topic and there's not great. It's like kind of an art sometimes to interpreting the aldorenin. I would say just do the aldorenin. The one thing to stop is spironolactone eplerenone. Don't do it while on that because it'll get a false negative usually. And those have to be stopped for 4 to 6 weeks. But the rest of the drugs, I'm not sure you guys should worry about stopping and rotating to things like hydralazine, verapamil, or doxazosin. You can if you want, because those three agents don't affect it. But then you'd probably want to be stopping for 2 weeks at least, maybe even longer. But the problem is if the blood pressure is high, you don't want to be stopping medications, right? I've seen cases where it gets stopped and then the blood pressure shoots up too much. They end up in emerge, which is terrible for our overworked emerge colleagues. So I think I would just go ahead and screen them and then send them along if you're worried, or call me. You can always call me and I can go over the numbers with you and give you my impression of what to do.
And then please comment on isolated diastolic hypertension. Is
Yeah, there's a lot of, sorry, Donna, to cut you off. There's a lot of literature early that said maybe don't treat it because it's in younger people primarily. I would treat it. Honestly, if anyone has hypertension, I would ultimately treat it. Now, if the blood pressure is kind of the 140, 150 range, 90, 95, maybe less than 100, and they're obese, you don't have to jump on it right away. You have 6 months, maybe even a year. Try to get them to lose weight. But you guys have you're lucky that you follow your patients for many years and you know them well. And then after 6 months or a year, or if your impression is nothing's going to change, then I would treat. But I would treat both systolic and diastolic because they both elevate risk.
and then this might be difficult. It's what change in number needed to treat by changing treatment target from 140 to 130, and what change in number needed to harm.
Yeah, the number needed to harm is lower than the number needed to treat. I can't remember it offhand, but it's probably like in the scores, like maybe 20, 30. But the thing about number needed to harm is it's things like dizziness, maybe hypotension that may or may not be symptomatic. So it's not nearly as terrible as having an event, I guess. Number needed to treat, I don't know about 140 to 130 because actually the studies didn't do 140 to 130. They did 140 versus 120, and the number needed to treat is around 100 in higher risk groups. Okay. So it is probably worth it, but as I mentioned earlier, it's not super compelling. It's not like a statin in secondary prevention, which is number needed to treat of around 20 to 30. It's like around 100. But I still think it's worth it if, as I mentioned, you can get there with 1 to 3 drugs and the patient's on board. But if you're starting to add a whole bunch of drugs, I wouldn't do that because a lot of those drugs are unproven, like the fifth, sixth, seventh line therapies.
And we're at time, but we have two questions. Do you think we could?
Yeah, let's get
Yeah,
them. Yeah.
let's let's get it. Your approach to hypertension and microalbuminuria.
Yep. So basically ACE ARB first, and then of course SGLT2, and then there's new data for finerenone. There's also data for non-DHPCCB like verapamil. So those would be the ones I'd be choosing amongst those, but definitely ACE ARB first, and of course SGLT2.
And then, what are some relevant considerations when treating primary hyperaldosterone in the context of renal disease in primary?
Well, yeah, so the biggest issue is you may not be able to use spironolactone at the dose you want, right? When the GFR is less than 30. And unfortunately, it is what it is. So you just have to go to other agents for chronic kidney disease. The best probably are the CCBs, but you may have to add agents. You may not be able to control them on monotherapy if they have PA and significant CKD.
And one last question came in, and that's should a patient on nifedipine having PR above 90 be of concern?
PR? Oh, pulse rate. Yeah. Yeah, that's a great question. I just saw a patient with tachycardia from the DHPCCB. I would rotate it out. I think there's no reason to make a patient live with B, especially if it's symptomatic. Rotate it out to you could do a non-DHPCCB. You could just lower the dose and up the dose of your ARB or your thiazide-like diuretic or add spironolactone or go to a combination agent. Or actually, you know what? You could go from nifedipine to amlodipine because there's less reflex tachycardia with amlodipine. But I would switch it out or lower the dose and try something else. I don't think people should have to live with that.
And I think we should end there. We did get one more question, but we're getting a bit over time and they can keep coming. So I would suggest we end and thank everyone for attending the webinar. Please remember to fill in your feedback. This really helps us in future webinars, and we do look at that and consider that. We do have another webinar coming up on April the 10th. That's Platelets Be Gone, Navigating the Latest in the Antiplatelet Therapy by Dr. Kevin Bailey. So thank you again, and thank you, Dr. Raj Padwal, for such an excellent webinar. Thanks, everyone.
Thank you.